Good morning, everybody. I'd like to introduce myself. I'm Kymberly Lengyel. I'm the Associate Administrator for Hospital Epidemiology and Infection Control here at Keck. So basically, I'd like to start with a little bit of a summary based on our confirmed cases that shows that basically our slope has not flattened yet. There are various models out there to determine the effectiveness of social distancing. We don't quite know yet if we have days to prepare, weeks to operationalize our PPE and then the way our hospital functions during a surge. So this could happen anytime, and we would expect a duration of a surge to last about 6 to 8 weeks. And this is really dependent on social distancing right now. So if we have mild social distancing and compliance with that, we could delay our countywide ICU occupancy all the way, maximum occupancy, from May 9th, with full occupancy being around May 16th. That doesn't account for any added from our patients from our Department of Defense, our SNFs, our ambulatory settings. If we have moderate social distancing, we could further delay that full occupancy all the way out to July, possibly with full occupancy being in August. It's just hard to say at this point. Next slide. So this is some of our current state in LA County, which I'm sure you've heard on the news. Mortality is doubling on an average of every 3 days. These are stats from yesterday at 12 p.m. We have had 4,045 confirmed cases in LA, 78 confirmed deaths, and 879 confirmed hospitalizations. At Keck, this is a very important slide, because though our occupancy for these patients is not at our peak yet, you're going to see in slides to come how much PPE we're actually burning through every day to make this very significant. So this slide will show you that the slope curve, how much time or how little time we actually have to operationalize this when we're at 85% occupancy. This next slide that we're on, the next slide shows that the personal protective equipment that we're looking for healthcare workers. Can you go back one, Tiffany? Yes, so the preferred PPE, what we're currently using today at Keck, and we want to actually continue to use at a minimum of this PPE, is our face shields with our N95, gloves, of course, and an isolation gown. There are other forms of PPE that are considered effective, but right now, our preferred method is as described. Next slide. So personal protective equipment right now, at the top, you can see there's a blue mask. That's actually an N95 respirator. That's our minimum protection that we're using at the bedside caring for these COVID patients, whether they're patients that are under investigation or patients that are positive. Down below that, you'll see a face shield. We want that face shield to cover all the way past the temple, just at the start of the ear. That's really important. There are a lot of models out there that are open on the top. That doesn't give that protection from droplets coming into the face. So we want to make sure that top of the face shield is closed. Basic surgical masks. We actually have people out there from our Ivan Young Academy sewing face masks from surgical wrap. Gloves are also very important. Shoe covers. We're not using shoe covers yet, but we will be getting there. So those are very important for us to have. Goggles are an alternative to face shield. Face shields are something that we would prefer because it protects the front of the N95 mask from contaminants. Also, hair covers. Many of our providers want to be able to cover their hair, though it's not a CDC recommendation at this time. We probably will be moving in that direction as long as we have enough hair covers. Tyvek suits, this is more for your ICU and very critical patients. You've seen this on the news. Many providers, almost every provider on the news they're showing is in Tyvek suits, but we're not at that point yet. We're still using our gowns. And then bottom, I guess it's my right, maybe your left, is the PAPR. And we'll talk more about that later. And I know Daniel from respiratory will be talking about that as well. Next slide. So personal protective equipment, I talked about our occupancy. You know, it's not that high at this time with these COVID patients, but currently our burn rate for our 3 hospitals is 1,095 masks a day. Face shields, we're going through 1,000 face shields, gowns, about 3,000, bouffant and hair covers, we're using at this point about 3,000 per day, 1,000 shoe covers. We're also using about 3,000 isolation gowns. And for our PAPRs, which are our respirators, the cuffs are disposable. We're using about 20 a day. When we would hit surge, our daily utilization of these supplies would at least double. So we would go up to 2,095 masks. We would use 2,000 face shields, 6,000 gowns, 6,000 bouffant covers, 2,000 shoe covers, 6,000 surgical masks. Possibly at that point when we're in surge, we would be going to coveralls, which are those Tyvek suits that you see. We would use about 3,000 a day and about 50 PAPR cuffs. So our current need for reusable, you can see what that is. I would say if we had a total of 6,000 reusable N95 respirators, which Daryl has been working very hard on. We've had many of our architects and engineers developing face shields. We would need about 6,000 face shields that are reusable for the organizations and about 50 PAPR cuffs and lenses. Current equipment needs that we see out there, about 30 UV boxes. This is for UV disinfection. We currently have 23 that have been made already from Professor Armani. So that's been very helpful to us. And also we need to have additional PAPRs or cappers. We're looking at additional ventilators and possibly somebody who can manufacture HEPA filters. Next slide. So we have approved disinfectants in the hospital that we're using. All of the equipment and supplies that are reusable would need to be able to be cleaned by 1, if not 2 of these methods. Our current method that we use most is the hydrogen peroxide, which is a 1.4% hydrogen peroxide. It has a 1-minute contact time, meaning that surface needs to be wet with the peroxide for a full 1 minute. We also use a disinfectant bleach. It's a 0.55 sodium hypochlorite solution or a 1 to 10 bleach dilution. That has a 3-minute contact time, but requires an extra step when we use that method because it does leave a residue. So we would normally wipe it with some water afterwards, but our preferred method for equipment is hydrogen peroxide at this time. We're also using UV disinfection. We're using that as a secondary disinfection. We would use our peroxide first before putting it into our UV boxes. And then we also have Pulsenon, which is our UV disinfectant robot, which we can use to disinfect some of our larger equipment. Next slide. So process for getting these devices approved at CAC. Number 1, we want to triage. Is this a donation or is it for sale? We also want to look at, is this a novel, non-certified piece of equipment? For example, the face shields. These are non-certified but very, very useful. So anybody that is providing that, please email Graciela Medina at med.usc.edu. She will then forward it to me, and then we will decide, yes, this is a design that we like. Then we would triage it to Daryl to see if this is something that could be produced in mass quantities. If you have certified equipment that you're willing to donate, gloves, masks, Tyvek suits, you would then use the donate protective gear at med.usc.edu. They will then forward those to me, and then I'll make sure that they meet our standard infection prevention needs. Step 2 would be Daryl for approval of any prototypes. Step 3, we want to ensure its infection prevention standards are met. Number 4, we want to qualify the deliverable based on need. And then step 5, we would then deploy it as emergency clinical use. So lastly, I'd just like to thank you all for your partnership in helping to keep our healthcare workers safe on the front lines, and stay safe out there.
Maybe 7 minutes or so, we have for question answer. I want to make this workshop largely discussion focused. So this is your time to ask him questions and kind of better understand what they really mean.
Perfect. So we've got a list already. First, coming from, is it Zia Brooks?
Yeah, Zia. It's Zia Borak. I'm Dr. Borak. I am Chief of the Division of Pulmonary Critical Care and Sleep Medicine at both Keck County.
Welcome, Zia.
And I guess I put some of these people in touch originally, and thanks to everybody for working together so that we could get it organized and not have multiple groups kind of working at cross purposes. I probably know the least of all about this than everybody on the call, so I defer to Kim, but I guess just one comment, and I am a bit of a skeptic to begin with, and your chair knows that, is that the CDC guidelines have lagged behind the reality by at least 3 to 6 weeks. So their recommendations are way behind. So for example, there are now emerging recommendations that everybody should be wearing a mask, which is we've moved into that at Keck. It's slightly variable at county, based on there being very high asymptomatic transmission. So a lot of our estimates about PPE could change over time as the recommendations change. And there's always been a discrepancy between what we really need versus the guidelines, okay? In other words, a balance of availability versus guidelines. The second thing is we do also service the county hospital. County seems to be taking care of their own PPE, but I also view us as one USC. So it is possible that there might be even more needs if we were to take into account both. And then related to my first comment, in China, they were at the end when they got their act together, as far as we can tell, using bunny suits. So I don't want to imply that the reason we're not using bunny suits is because we're not in a surge yet, that only surge requires that. There is a consideration that in fact bunny suits might be the standard of care. That's just not the recommendation. But that goes back to my point about CDC being a little bit behind. And hair is potentially a major reservoir for the virus for those taking care of it. So I actually feel that head coverings should not be optional. And some of it's based on very sort of anecdotal data out there. But I think I read an article last night that came out in Nature that was very persuasive for me, because it's actually showing that unlike the other SARS and MERS viruses, which tended to replicate mostly in the lower respiratory tract, there's significant replication going on in the upper respiratory tract, which might account for why this is so infectious. I don't think it's necessarily the infectivity, it might be the site of the replication, which is allowing it to spread more easily. So those are my comments. Kim, I hope I didn't contradict anything that you were saying, and Daniel, you can take it on from that. And the reason that I'm so passionate about this is that my people are actually on the front line, so I want them to be protected.
So yes, that's why I did bring up the bouffants, that we are looking for even people who can sew those type of things to make sure we have enough, and the shoe covers as well. So, and the Tyvek suit is also on there. So I appreciate your comments. Thank you.
Dr. Gupta, this is Neha Nanda. I'm the hospital epidemiologist. Can I just add something to what Dr. Borak said?
Absolutely.
Thank you, Zia, for chiming in. So I think to just add to what Dr. Borak just mentioned, this is very infectious, and the way we measure that, you must have already seen in so many papers, is the reproductive number, right? So the reproductive number is the ability of this virus to infect the number of people from the index patient. And that number for influenza is around 1.5. But for this, it's probably north of 3.5, which is more than SARS, but less than Ebola. And like Dr. Borak said, that the bunny suits is something we are invested in. And Dr. Borak, we're not going to wait for a surge. No. My hope is that in the respiratory units, our isolation wards, we are hoping to deploy those if we have a supply and appropriate education has been imparted to the stakeholders.
SK, is it okay if we move to the next question from Jill Henley?
Hi, excuse me, Jill Henley. So I come from the research side of things. So I operate the Biosafety Level 3 laboratory here at the Health Science Campus. And my question is in regards to disinfection for possible reuse. I noted that there was no comment on the vaporized hydrogen peroxide. Is that something that your team is looking into, or is it just a matter of not having equipment or utilization? Can you just comment on that?
Kim, do you want me to take that?
Yeah, go ahead, because that is something that we're looking at, actually real recently. So go ahead, Dr. Nanda.
Yeah, so Dr. Gupta, I don't know if I've introduced myself. Should I go ahead and do that, or is, yeah.
You can answer the question now, and then you can introduce when you are.
Yeah, because yeah, Jill, I'm the hospital epi person, epidemiologist, and the medical director of infection prevention, the department that Kim is representing. So I'm very, very skeptical of all equipment where we are, you know, trying to mobilize it in the hospital. And the reason I'm skeptical is because we do not have at this time a standardized way of disinfecting / sterilizing these instruments, these equipments. Typically, the way it's done, as you may know, is that we create bioactive aerosols with the appropriate virus and then look at the log reduction based on the disinfection / sterilization technique that we use to reuse these equipment, to reuse this personal protective equipment. At this time, from my reading and talking to my colleagues across the country, the two modalities that we have specifically for N95 masks is UVGI and the vaporized hydrogen peroxide, like you mentioned. Between the two, I think what we know is that UVGI initially, we had some confidence in it, but as we learn more about it, we are not so excited about it. Hydrogen peroxide, we have little information because it's just been used in Ohio, as you may know, and therefore it seems to be more efficacious than UVGI. But to answer your question, yes, we are actively looking, and I'm hoping to collaborate with someone to actually look at the log reduction after we disinfect our personal equipment, so we have the avenue of reusing, so we have the confidence in that avenue.
Okay. So I'll just, one last response to that. So we've been using vaporized hydrogen peroxide for decontamination of risk group 3 agents for the last 5-6 years within our BSL-3 laboratory. So if you need any additional information, operation information, we're more than happy to reach out and help out with that.
So Jill, can I connect with you offline?
Absolutely.
Perfect.
Thank you.
Thank you both so much. We have a question coming in from the chat box from Vidya.
So Tiffany, in
Yes.
the interest of time, I'm also paying attention because I know that some of our friends from Keck are under a strict, schedule,
Yes.
and they need to get back. So in the interest of time, let's collect the questions. We will get them answered, but let's just move on to the next speaker at this point.
Perfect.
Great.